A diagnosis of prostate cancer is made following a biopsy of the prostate gland. Obviously, this is a troublesome time for men and their families faced with a new cancer diagnosis. Part of the difficulty for men at this stage is, number one, dealing with a diagnosis of prostate cancer, but then being faced with a variety of different treatment options that are available for a man and having to choose a particular solution that suits him and his family. So going back to the beginning, the first thing that we have to do when we establish a diagnosis of prostate cancer is confirm that the disease itself is confined to the prostate gland. What that means is that we need to stage the disease. And by stage, I mean we need to confirm that there is no obvious evidence of spread of prostate cancer beyond the shell of the gland to any other areas of the body. What we know with prostate cancer is that it spreads in different ways. It can spread via the bloodstream, and when it does, it can go preferentially to the bones, and it can also spread by the lymphatic system. When it spreads via the lymphatic system, it goes to lymph glands that are present within the pelvis. Part of the staging process involves two additional tests. They are a bone scan and, in the majority of cases, a CT scan of a man's pelvis and his abdomen. And these tests allow us to confirm that we're dealing with localized disease. I perform staging tests for men that have what we call intermediate and high-risk disease. Following a diagnosis of prostate cancer, there are three main clinical characteristics that we look at to put a man's disease into a particular risk group. These features include what the PSA is at the time of diagnosis, how the prostate feels on the digital test, that gives us the clinical stage, and also the Gleason score. And the Gleason score is the number that the pathologist attributes to the particular pattern of disease that he or she sees under the microscope. So, staging tests are not routinely performed for men with low-risk disease. They're reserved for men with intermediate or higher-risk disease. So to give you an example, a man with low-risk prostate cancer would be a man with a PSA test that's less than 10, a benign-feeling prostate gland, and a Gleason 6 cancer. A man with intermediate risk disease would include a PSA of between 10 to 20, a nodule within the prostate, but without that nodule appearing to extend beyond the shell of the prostate, or alternatively, a Gleason 7 cancer. A man with high-risk disease includes a man who has a PSA greater than 20, a palpably abnormal prostate where we feel that there is disease in both sides of the prostate, or alternatively breach of the shell of the capsule of the prostate. We call that extracapsular extension, and that's a clinical T3 cancer. Or alternatively, men with Gleason scores of 8, 9 or 10. They're more aggressive cancers. So once we've established a risk group, we can then talk about the treatment options that are available for a particular man. Treatment options include active surveillance, surgery in its varying forms, and radiotherapy in its varying forms. Active surveillance is a treatment option for men that have low-risk disease. Active surveillance means observing the cancer. We think that the likelihood of a low-risk prostate cancer causing a man harm is relatively low, and therefore what we aim to do with active surveillance is to monitor the disease very closely. So if there are signs of change or progression, we pick it up at an early stage, but we miss out on the potential side effects from either surgery or radiotherapy. An ideal man for active surveillance is a man with low-risk disease and someone who is committed, compliant, and amenable to having periodic trus biopsies to re-evaluate the state of disease within a man's prostate. Surgery can be performed in a variety of different ways. It used to be done in an open fashion and in many centres is still done in an open way. That involves a single incision in the middle of the tummy. It can also be done in a variety of different minimally invasive ways. That includes keyhole surgery or laparoscopic surgery, or alternatively robotic assisted keyhole surgery. Both of these approaches have an advantage over open surgery in that the risk of blood loss is less, the risk of needing a blood transfusion is less, your time in hospital, certainly within Australia, is less, and your recovery is quicker. That's the main advantage to these minimally invasive options. And more men today are electing to have minimally invasive surgery so they can get about their normal routine and get back to their normal life as soon as possible. Radiation treatment can be done in different ways. It includes external beam radiation and something called high-dose rate brachytherapy, where needles are placed into the prostate to allow an increased dose of radiation to be delivered. For less aggressive cancers, we can also implant very small seeds, radioactive seeds, into the prostate. That's called low-dose rate brachytherapy. That's an acceptable treatment option for men that have low risk or low volume intermediate risk disease. So to recap, for the man with localized prostate cancer, his treatment options include active surveillance, surgery in its varying forms, or radiotherapy in its varying forms. And at the end of the day, the final choice comes down to a man, his family, and their discussion about what is an appropriate treatment option for them.